This disease has challenged everything that we believed was right 6 weeks ago.
It's different than anything we've seen before, and maybe the way we've taken care of things is not the right way of doing it.
There is a lively and healthy debate that I think is a good debate about what the right thing to do here is.
I'm concerned that if we continue on the path that we're on, that hundreds of thousands of lives and lungs may be at risk.
It's actually kind of vital that we not deviate from those treatment protocols because we know that they reduce mortality.
If you ask physicians a month and a half ago, hey, someone comes in breathing 40 times a minute.
Low oxygen levels.
Somebody who has an O2 sat in the 80s.
They will tire out within a few hours. So what's your next step?
Before COVID-19, I would recommend putting you on a breathing machine.
I would have rushed to intubate.
Because that was probably the right thing to do.
You know, I know when to put in a breathing tube. I've worked long enough and I've worked enough places and with enough people. But in this disease, it is extremely confusing. You know, it just doesn't make sense. ICU, you have very sick patients. Patients are dying, but this is just different. It's just, you have a disease we don't understand that is very deadly, with patients that are scared and staff that are scared. And on top of that, it does not appear that we have a good treatment strategy other than a ventilator. And we're not sure when to put a breathing tube in. You know, the crux of it is we don't want to put a breathing tube in to someone who doesn't need it, knowing that there's a 70% chance they'll die. And then we don't want to not put it in to someone who would need it too late. You go to the ER and there's 40 people that need oxygen and they all look terrible, but they can all talk to you.
And no apparent distress whatsoever.
And then you get them on a monitor and you look up and you see this oxygen saturation of 45 or 50%.
And I'm telling myself, this is impossible. This is not possible. How can this be?
It's just not compatible with life to have an oxygen saturation that low.
You know, this is strange. It's out of a horror movie.
I've been unable to sleep because I'm trying to wrap my head around this. This goes against anything I've ever believed.
The paradigm of ARDS is not matching with the patients that I'm seeing. So it's like trying to fit a square peg into a round hole.
At the core of the core of the core, it is just, what disease are we treating, you know? And are we treating something that is naturally ARDS, or are we not?
We protect the lung against what we do to the lung. Protect it from what? From what we do in mechanical ventilation. And now the mechanical ventilation. The type L cannot be treated as a classical ARDS. It's not a classical ARDS. You cannot do the same protocol for everybody. If they come and you don't have an idea if the patient is type L or type H, you probably do some disaster in 50% of the population.
So what he is saying is that we just have to be gentle. You know, people will need a ventilator, and those that do need as high oxygen as possible, as little pressure as possible, in order to buy time until this demon virus stops.
These patients have ARDS. I think the editorial has both been misinterpreted, and I think people have misunderstood that it's just that. It's an editorial, it's not a study, and it's not a trial. I don't doubt that people have seen some cases with some terrifyingly low oxygen numbers. On average, they're as sick as prior cohorts with ARDS.
I just think it's important to say that it's not a settled question. Every hospital in the world is probably solving this problem slightly differently.
We're using an early intubation strategy here, and of our first 66 patients, already a third of them have been extubated. I'm arguing for evidence-based medicine, which is something that we all purported to agree with before this outbreak hit. We have large randomized controlled trials. The patients in those trials had met the same diagnostic criteria that our current patients meet. We should apply the results of the trials.
Today, we do not rush to intubate. Intubation has become the last resort, and the protocol, once they're intubated, has changed drastically.
So within the last 2 weeks, I think what has been unacceptable has become very acceptable. Some of these patients don't need to be intubated. You watch them carefully, you make sure their oxygenation is adequate, and they can recover.
I'm not saying we don't need ventilators, but perhaps we need to think about how we're using them. Somebody, and preferably people that are not taking care of patients every day, needs to look at the disease and figure out how we can treat it better.
The truth will come out eventually. In the meantime, the question is what do we do till that happens? And yes, I'm nervous. I'm scared every day when I go into work. But I'm just trying to do the best I can.